Hello, everybody. We would like to welcome everyone and thank you for joining today's town hall. Just before we do get started, we wanted to let you know that there is a short pre-town hall survey, which you all should be seeing on your screen. So please feel free to answer the questions, and there will also be another one at the end of this event. The purpose of this survey is to measure what everyone learns from our speakers today. So please take the time to answer the questions that are coming up. And then just as a heads up, there is the Q&A box at the bottom of your screen. So please feel free to type in questions as they come to you throughout the presentation. And we will be addressing them at the end. So please feel free to ask as many questions as you want. And let's see, my name, just for introduction, is Olivia Trujillo. Yat A She'e Olivia Trujillo Yanishia. Ashihen Nishlin, Tinsakani Bashishchin, Kia Ani Jashiche Do Bitahni Dashanele. I currently work as a research program coordinator with the center's training team to be exact. So I'm happy to be here with you all. And I'll now pass it over to my colleague, Leoma, so she can also introduce herself.
Okay. Good day, everybody. My name is Leonla Nelson, and I am located at our Shiprock, New Mexico site. So for me, it's still morning, but I know there's people all across the country. So we just want to welcome everybody. Good morning, good afternoon. She'e Leonla Nelson Yanisha. Ashta and Shlendo Tkohana, Bashichin, Husk Ahadzo, Eda Shichedo, Kia Ani Dashanella, Isans Bastant, Nasha. And I just wanted to give you a little intro about our center. So at Johns Hopkins, the Center for American Indian Health, we work in partnership with tribal communities to support and implement public health programs with a mission to promote health equality for Native Americans. The center's work includes behavioral, mental, and infectious disease prevention and higher education and leadership development. This is the first town hall out of a two-part series with the goal of increasing COVID-19 vaccine confidence and as well as other COVID-19 prevention behaviors for Native peoples. So please look out for our future series, our future continuation of a four-part series live training webinars. So today, our topic is on protecting our community's COVID-19 vaccine considerations in Indian country. We look forward to hearing from our guest speakers who are going to dive into the COVID-19 vaccine. It's kind of like a 101 lesson and give us a better understanding of what vaccines are and how they work. We will also talk and we will hear some case examples as well. From different tribal communities, as well as consider indigenous that consider an indigenous lens on public health approaches.
Now,
and go ahead, sorry.
Sorry. We just want to now introduce our two speakers for today. Dr. Sophina Mannheimer Calderon is Diné, Navajo from Tuba City, Arizona, and is a graduate of Dartmouth College. She obtained her medical degree at University of Rochester School of Medicine and Dentistry. She completed her residency at the University of Rochester Medical Center in Rochester, New York. She trained as a family physician with an emphasis in women's health and global health. Dr. Calderon currently works in multiple clinical settings at Tuba City Regional Healthcare Corporation on the Navajo Nation in Northern Arizona. She is the Deputy Chief of Staff and is the co-chair for the Medical Staff Credentialing Subcommittee. She is the HIV officer for Tuba City Regional Healthcare Corporation, providing subspecialized HIV/AIDS treatment and prevention for adults and adolescents on the Western Navajo Nation. With a commitment to global health, Dr. Calderon also serves on medical brigades to Honduras with her University of Rochester Family Medicine Residency Program. Previously a resident physician participant, she now supervises family medicine residents on a mission to improve the health and welfare of a Southwest rural community of Honduras. The program teaches its resident physicians the skills necessary to help other communities improve their health, a skill that Dr. Calderon is grateful to bring back to her hometown community of Tuba City. Dr. Calderon received the 2017 Humanitarian Award from the University of Rochester School of Medicine and Dentistry, which recognizes dedication to providing medical care to the underprivileged and underserved. Most recently, she has been assisting the EPI response team at Tuba City Regional Healthcare Corporation with their COVID-19 response to the pandemic. Her focus has been on community education and outreach. Thank you so much, Dr. Calderon, for being here. And
I will introduce Dr. Donald Warne, MD and MPH. He is an Associate Dean of Diversity, Equality, and Inclusion, as well as the Director of the Indians into Medicine and the Public Health Programs, and a Professor of Family and Community Medicine at the School of Medicine and Health Sciences at the University of North Dakota. He also serves as a senior policy advisor to the Great Plains Tribal Leaders Health Board in Rapid City, South Dakota. Dr. Warne is a member of the Oglala Lakota tribe from Pine Ridge, South Dakota, and comes from a long line of traditional healers and medicine men. He received his MD from Stanford University of Medicine in 1995 and his MPH from Harvard School of Public Health in 2002. His work experience includes several years as a primary care physician with the Gila River Health Care Corporation in Arizona, a staff clinician with the National Institute of Health, Indian Legal Program faculty with the Sandra Day O'Connor College of Law at Arizona State University, Health Policy Research Director for Intertribal Council of Arizona, Executive Director of the Great Plains Tribal Chairman's Health Board, and Chair of Department of Public Health at North Dakota State University. Dr. Warne is also a member of the Stanford University Alumni Hall of Fame. We're so excited to have Dr. Warne today.
We are so grateful to our speakers for being here today. And now we will pass it on to Dr. Sophina Calderon to get our presentation started. Thank you both.
Thank you, great introduction. I am very excited to be part of this panel. And so I will start off with just sort of a basic science background, but also really focusing in on a lot of the sort of the reasons why a lot of people are still hesitant out there and some of the things that we still think about when we are talking about vaccines and the things that worry us still to this day. So that's a little bit of my focus today. So I'm actually going to turn off my video so that my audio will come across much more clearly, given my poor internet connection. So next slide. So just to begin, I have no disclosures. I'm not going to be advertising anything through this presentation, and also any of the opinions that I expressed throughout this entire town hall are actually my own opinion and don't reflect any opinion from the Indian Health Service or the hospital that I work for. Next slide. So just an overview, I am going to just sort of do a brief, quick, browsing through quick slides through an overview of where we've come so far in this pandemic and some of the complications and some of the things that we worry about in terms of, many people have been sick thus far and have been experiencing COVID-19, and what are some of the things that people continue to deal with after recovering from COVID. And then I'm going to do a brief overview of the vaccines that are available here that have emergency use authorization here in the United States, the benefits of these vaccinations, and then diving in deeper into talking about some of the things that a lot of people are worried about, the chit chat about the adverse events that are reported about these vaccines, a lot of the myths about these vaccinations, and just really gaining a better understanding of some of the things that still worry us about getting our shots. Next slide. So just a quick look here. This is the trajectory of how COVID-19 has occurred here in the United States. There have been several waves, the largest over the winter months. And so as you can see on the far right, we finally are coming down with vaccinations that started in December and into January and have really taken off for the past couple months that have really contributed to bringing our numbers down. Next slide. And looking at our cases, and just this is a really great breakdown of by race and ethnicity. And American Indian Alaska Natives here are pictured in yellow. So that orangish yellow solid graph, which is sort of the second from the top, you'll see that our number of cases among our Native people have actually peaked along with the rest of the pandemic in the winter months, and our numbers were quite up there. Next slide. And this slide actually depicts the deaths of by race and ethnicity as well. So again, American Indian and Alaska Natives are pictured are depicted with the orangish yellow solid bar line. And so that, our numbers are sort of have been staying at the top end of things. And so during this whole course of the pandemic, our rates of death per 100,000 in our population have actually remained on the higher end of things, even though we don't make up a large proportion of the entire US population, but our numbers are quite up there in terms of COVID cases and death rates. Next slide. So a lot of the things that, we've been sort of, as time has gone on, we've been sort of following some of the conditions and risk factors that contribute to severe COVID illness. And so on the left-hand side, this is just a list of a lot of the case studies that have, and a lot of reviews that have been studied in terms of some of the established risk factors that we know of and some that are probable. And then the right side is just sort of a list that we've observed. And so you'll see on the left side, among the highest, the well-known risk factors for severe COVID-19 and COVID-19 death are diabetes, being overweight and obese, cancer, kidney disease, lung disease, history of heart conditions, and pregnancies up there as well. So these are, and as you know, on a lot of our Native populations do suffer higher rates of diabetes, higher rates of obesity and cancers. And so that in itself really puts our entire Native population at higher risk for severe disease and death from this illness. Next slide. And so as, with time, as people have, been getting sick and recovering, and as we see people in clinic, and I see a lot of patients that have been both discharged from the hospital, but also coming to see me for the first time after recovering from COVID because they had milder to moderate symptoms that they didn't need to be hospitalized, but they are coming in because they are having persistent symptoms of COVID. And there's, they come in and they say, well, I recovered 2 months ago and I had COVID 2 months ago, but all of these symptoms are still here. And I feel like I still have COVID. And they have long tested negative, and some of them have retested and they're still negative. And a lot of them are thinking, am I still, infected with COVID? But, COVID really has taken a large toll on a lot of our people, and a lot of symptoms seem to persist. So listing from top to bottom, these are the most frequent symptoms. So a lot of people feel significant amount of fatigue and feeling like they're not even back to their baseline energy, shortness of breath, and just feeling like they can't really get around and do very much, and a significant reduction of quality of life. So people just feeling like, especially if they have these ongoing symptoms that really bother them and really worry them significantly, and sort of wonder what else might be going on. And especially if you've been previously healthy and you're on the younger end of the spectrum in the population of having gotten COVID, you did fine, you recovered at home and didn't need to stay in the hospital, but there are just still some symptoms that still persist and bother you. And you wonder, is my heart okay? Are my lungs okay? And so I do see a lot of patients that come back to the clinic with these persistent symptoms, and some that still don't feel ready to go back to work. So it has really affected a lot of us, not just the people who have been admitted to the hospital on oxygen and finally discharged, either to a rehab facility for rehabilitation and strengthening, but even just people who have been positive and didn't need to end up in that didn't need time in the hospital are still experiencing a lot of these symptoms. Next slide. So a brief overview of the COVID-19 vaccines that have emergency use authorization here in the United States. So the first two that were released were Pfizer and Moderna, and then Johnson & Johnson on the right. So Pfizer and Moderna, they're both 2-dose vaccines, and Pfizer's given 3 weeks apart and Moderna is 4 weeks apart. All 3 shots are given in the arm. Now, Pfizer and Moderna are mRNA vaccines, which is actually technology that is quite new. They've used it before in other vaccines in the past, and never have gotten so much success with a vaccine in this rollout, with as fast as things have rolled out over the course of the pandemic to develop this vaccine, and to develop something so successful as having a 94-95% efficacy rate in terms of reducing COVID infection and spread. And and as you know, just over the past couple of days, Pfizer has expanded and gotten emergency use authorization to expand down to giving the vaccine to as young as 12 years old. Previously, we were vaccinating 16 and over with Pfizer, and over the past couple of days, 12 to 15-year-olds have now been given authorization for getting their vaccinations as well with Pfizer. So that is well underway. A lot of facilities across the nation are now vaccinating the 12 to 15-year-olds. And then Johnson & Johnson's a little bit different. It's a 1-dose vaccine. It is an adenovirus vector vaccine. All 3 sort of do similar things in terms of how it gives you immunity. All 3 vaccines sort of send a message into our cells and tell our cells to make a protein called the spike protein, which is, if you've seen all of the pictures of coronavirus, you see those red spikes on the outside of the virus. These vaccines actually encode for a protein similar to that spike protein, and stimulates your immune system. When your immune system sees this spike protein that your cells have created based on the message that your cells got from Pfizer, Moderna, and Johnson & Johnson, your immune system revs up and it develops a response against it and gives you a lot of good antibodies and immune protection, so that if you were to happen to encounter the actual COVID virus, in the future, your immune system should rev to protect you from it settle as an actual infection in your body, or reduce the risk of a severe infection. Next slide. So, this is just a brief overview about vaccine development and sort of the oversight from a government level of how we've been managing, and, the studies and a lot of people who've been sort of reviewing our vaccines and making sure that they're safe for us. So, our vaccines go through phase 1, 2, and 3 trials, and, basically just starting from figuring out, the safety of it and what our bodies would do in reaction to the injection, and also developing, how safe it is, if there are any side effects, and also, most importantly, developing an idea of how good the vaccine is to giving us that protection against whatever illness that it's developed for. But in our case, for COVID. And so, in this rollout, the phase 1, 2, and 3, there was a lot of overlap, just given the urgency with which we were needing a vaccine to protect us and reduce the ongoing spread of this virus and this illness. A lot of these phases had a little bit of overlap. 1 and 2 was overlapped, and in some of the trials, 2 and 3 were overlapped. But what's important to note and understand is that there were no quote, shortcuts that were taken through the development of this vaccine. And in terms of the testing and the rigorous sort of scrutiny that went into sort of evaluating and assessing how safe it is, all of those precautions and all of those steps were appropriately taken. And so the FDA has given us emergency use authorization, which means, they have, this emergency use authorization was designed to really get the product out there and make it available to us in this public health emergency. And so the FDA has to see a substantial benefit for the safety and effectiveness of the vaccine in order to give us this authorization in comparison to what we're facing right now with the spread of this virus. And they get a lot of guidance from a whole panel of clinicians and experts in vaccines and epidemiologists that sort of give them a lot of advice on evaluating these vaccines. And and all of these people who review it are actually not related to or have anything to do with having done the study itself, developed it, or get any benefit on a personal level from any of these vaccines. Next slide. So, and as far as the vaccine rollout has gone, as of the other day, there are well over 260 million people that have received the vaccine. And in the dark areas across the United States there that you see pictured, these are the areas that have been heavily sort of infiltrated, the most vaccinated areas, and it goes from lighter to darker. And you'll kind of see, parts of the United States that have taken very well to accepting the vaccine and really making a point to get a large portion of their populations vaccinated. Next slide. And so here, this is a really nice depiction that the CDC has put out in terms of, getting the vaccine out there, and among the race and sort of a breakdown by race and ethnicity. So when the vaccine came out, we were all ready, and we were getting sort of tips well ahead of time about when and timing for the vaccine and when it was going to happen. And everyone up ahead got ready for the vaccine and had developed a huge rollout plan, very, very detailed plan about how to get this vaccine out and get it into as many arms as possible. And so you'll see the yellow graph is actually the American Indian Alaska Native people, and our populations have done an excellent job at getting our vaccines out there and getting the most people vaccinated in comparison to the other races in the United States. Next slide. So in terms of the benefits of vaccination, so we look at, I mentioned in a previous slide, we talked about the efficacy in terms of 94-95% for Pfizer and Moderna, 66% for Johnson & Johnson vaccine. But what's most important about all of the studies that have been done about these vaccines is how well it prevents against severe illness. The chance that you would get severely ill and end up in the hospital, and beyond that, how, the chance that you might get severely ill and might pass away from COVID. And so these vaccines, all three, are equally as great at preventing these types of spread and illness. And even just among the people who, even after getting the vaccine, some have had asymptomatic or tested positive for COVID without any symptoms. And even those who have had symptoms have had very, very mild symptoms overall. And it just really significantly reduces the experience that people might have having the illness, but also reduces the transmission of the infection as well. And one of the great things about it that a lot of people have been, as we've been hearing about the variants that are out there, and sort of, the time is a bit more urgent now that the variants are popping up. So far, the vaccines have been shown to still provide a good amount of protection against the variants that are popping up out there. But also, as these variants are happening, it makes it much more urgent to stay ahead of the game and get everyone and get as many people as possible vaccinated, so we could stop the further transmission and further, mutations and new variants that are popping up. So we got to stay pretty far ahead and keep preventing the ongoing spread of it, so that we won't keep dealing with, more complicated issues down the road. I just have a couple of patients actually. I saw a family last week that had attended a small birthday gathering. And if you know Native families, when we gather, it's usually an extended, huge gathering. But this one, they kept it pretty small. But fortunately, this entire family, everyone 16 and over in the family, was all vaccinated, and they had this gathering. And afterward, the younger children who weren't yet vaccinated had gotten this, cough and cold, a little febrile. After a couple of days of working with the kids in terms of treating their quote cold, they finally took them in to get tested, and it turned out that 2 kids were positive. And so, if you can imagine the whole family being shocked and going back and trying to backtrack and think, okay, who did these kids have contact with? Oh no, grandma was there, uncle and auntie were there, and notifying everybody to get tested as well. And at the end of the day, once everyone was tested and the results came back a couple of days later, all of those who were vaccinated, which was pretty much all of the adults that attended the small birthday gathering, only one person tested positive, which was grandma. And everyone was sort of really scared. Grandma tested positive. However, she was well beyond vaccinated, and she was she got her full vaccinations and completed her 2-shot series 2 months ago. And so when she tested positive, everyone was very surprised because she did not have any symptoms. And she said, well, I feel fine. I don't know why I tested positive, but everyone else gratefully had tested negative. And the family just felt like such a huge sense of relief that everyone had been vaccinated, and just a really true, testament to the effectiveness of this vaccine protecting their family. Next slide. And so this is a list of a lot of the adverse events, and some of the buzz around some of the things that people might fear about getting the vaccine. So first of all, just the regular plain side effects. There's always a little bit of pain at the injection site, a needle in your arm. So you're always going to be a little bit sore from there. But there are secondary effects of possibly lymph node enlargement, especially in the axillary area. So some of the lymph nodes in the underarm might get a little bit enlarged on the side that you got the shot. So for this reason, scanning all the way down to the bottom, we've been telling people to hold off on getting their mammogram screens, because there have been actually, when people got their shot and got their screening mammogram done a couple of weeks later or a week later, some of the lymph nodes were enlarged and sort of popped up as sort of a warning spot during their mammogram screening. And actually, sure enough, a couple of weeks later, waiting it out a few weeks later, and rechecking and following up with an ultrasound showed that it was just sort of a transient lymph node enlargement that was temporary, that resolved on its own, and then follow-up mammogram screening turned out negative. So for screening purposes, we're recommending that people hold off on their screening mammograms for at least a month after getting their shot. And then people sometimes get a little bit of low-grade fever, sometimes tired for a day or two, and some headaches after getting a shot. And then anaphylaxis, at the beginning, there was a big buzz around people developing huge anaphylactic reactions to the shot right after getting it. So anaphylaxis is an immediate reaction. Having an allergy to something in the vaccine, or even a history of anaphylaxis to other agents, might trigger you to sort of be a bit more cautious about getting the shot, in terms of waiting a little bit longer to make sure you don't develop a reaction. There are, at all vaccine sites, there are EpiPens available, and we all, I think I've only had to administer Epi once. Actually, it was a patient who, doing vaccine blitzes and things like that, we don't necessarily have access to a lot of our patient charts. And a patient had actually come to our vaccine blitz that I was working at, and she came from a town further away. And so she had an immediate anaphylaxis reaction, and we gave her Epi. She's fine and had to stay in the hospital one night for monitoring. But after I gave her Epi, and when she could talk again, she said, I should have told you the truth. I should have told you that I get anaphylaxis to flu vaccine. And when I had asked her if she's gotten flu shots before, and she said, oh yeah, fine. So there are people out there that, have had these history of things that are really still trying and wanting to get the vaccine, because it is, to get that protection. And so usually anaphylaxis is a reaction that you see in people with other history of anaphylaxis or other severe allergies to other things. And then the other thing that's been the more recent buzz, especially with the Johnson & Johnson vaccine, and if you know people in Canada, AstraZeneca has also had some cases of this as well. So thrombosis and thrombocytopenia syndrome, or TTS, or the rare blood clotting event that people have been talking about. So this is pretty much just a cascade of and a reaction where your body sort of develops antibodies against platelet factor 4. And so then it just really depletes your platelets and kills off your platelet cells and your ability to, to kind of keep your blood thin. And so so then people develop these clots, and the more, it's quite rare. So they did the pause for the Johnson & Johnson vaccine and sort of did a huge study and evaluation of the 7 cases that of the cases that happened around the time that they did the pause. And so numbers wise, it is still very rare, 7 in 1 million, 7 in a million chance that this could happen. So very, very rare event, but also important to note that it happened in young women 18 to 49 years old and within a couple of weeks of vaccination. So I know we've had a lot of phone calls and people calling back and saying, well, my mom got the Johnson & Johnson and she got it a month ago. Should I still be worried? And, we only say, monitor these things for about 3 weeks after you get your shot and watching out for symptoms like a sudden severe persistent headache, blurry vision, maybe some chest pain and trouble breathing. These are things that if they happen all of a sudden, leg swelling, stomach pain that doesn't go away, that's new and severe, and some bruising and bleeding that where you see some interesting spots in your skin and stuff. And so there's a workup plan for that, and there's ongoing monitoring for this. And so we've been for those who still want the Johnson & Johnson vaccine, we've been telling people, it's perfectly, okay to continue to get the shot. It's a really good vaccine. It's a 1-dose vaccine, and it works really good to prevent severe COVID and death from COVID. And so the other thing to keep in mind as well that we've been telling people is to be aware that you should not have gotten any other vaccines over the prior 2 weeks prior to the vaccine that you're going to get. And so this is actually much more important now that we've gotten approval for 12 to 15-year-olds to begin getting the vaccines now. And so, that a lot of your kids who go to well child visits, they all get their vaccines updated. And so there's shots every year that we sort of follow with this adolescent age group. And so it's important that when you go to your next well child check, if your plan is for your child who's 12 to 18 to get their shot, to hold off on their well child immunizations until they get their COVID vaccine, and then they can do their follow-up well child shots about 2 weeks after they get their COVID shots completed. Next slide. So in terms about vaccine hesitancy and some of the, this is sort of a small collection of things that I've, in talking to people and patients, some of the things that people continue to worry about out there in terms of, how the vaccine had rolled out so fast, and just this perception that there were a lot of shortcuts taken in terms of, our safety assessments and how well we've sort of scrutinized these vaccines and how well we've studied them. And that is actually not true. The vaccines were equally as well scrutinized, and they've gone through all of the appropriate phases for the vaccine. It just happened a lot faster, and there was a little bit of overlap with some of the phases as well. And then there's still a lot of misinformation that's circulating out there about the vaccine, about the infection, and people still having a significant fear about the side effects from the vaccine, and concerns about, this is a new vaccine. What's going to happen later? If I get my shot now, will something happen to me down the road? And will something happen to, if I have children, will something happen to my children after I have kids? These are all valid concerns. And just also what's floating out there is a significant amount of mistrust of, the process and, the government bodies, and sort of relating and, blurring the lines between politics and science. And I believe Dr. Warne will touch upon some of these things as well in his presentation. Next slide. So some of the floating myths that are out there. So Specifically, I've heard people be concerned about, if the vaccine is going to change my genetic material. So if this is, hearing the word mRNA and, with the Johnson vaccine, the adenovirus vector vaccine that has incorporates a little bit of DNA material to code for these spike proteins, people think, okay, it's going to come in and it's going to invade my DNA and it's going to change my genetic makeup. So the truth is that, these messengers, mRNA messengers that sort of send the code into your cells to use your cell machinery to produce and make these proteins, they don't incorporate and it's just the way they're made. They do not incorporate into the genetic makeup, into your own DNA. Our own DNA is actually housed inside the central nucleus in our cells, and these mRNAs don't even go anywhere near or go into the nucleus of our cells. And so they only last a couple hours, at most 48 hours, that the mRNA, the message gets into your cells. You're producing the spike protein to stimulate your immune system, and the mRNA that went in, the messenger, disintegrates with time, and it only lasts, not even beyond 48 hours, and it just lasts long enough to give us the message, and then the spike protein that it makes in your body to sort of stimulate your immune system, that spike protein also does not last very long either. It disintegrates on its own within a couple of days, and then pretty much 2 days out, there's not really much of a trace of any of these mRNA protein messengers, but also the spike protein as well. And these and so the next concern that people have brought up was, will the vaccine affect my ability to have a baby in the future? When we looked at our list of and some of this concern is people asking, can I get the vaccine when I'm pregnant? And pregnancy is one of the known risk factors to, for severe COVID and death. And there are certainly a lot of women out there who are pregnant that got COVID that didn't fare very well, unfortunately. And so, and what's more beneficial to a lot of these women is to get the shot, provide the protection, and deliver the baby. And also, when you and a side note too is that when you develop and create these antibodies to protect yourself, when your baby is born, you're going to pass off some of those protective antibodies for your baby as well. And so your baby will also benefit from it, even though the baby won't be able to get their shot when they're born. And so in terms of the whole, affecting babies in the future and the ability and fertility, there have been no direct links in some of the case reports that have been floating out there in other countries about, affecting fertility and things like that has been well looked after and has not been shown to be proven. And the next one is CDC is mandating that I get the COVID vaccine. Is the government going to require me to get the shot? And so from higher up, it's important to note that, the federal government doesn't mandate or require vaccination for people. And, the CDC doesn't maintain or monitor a person's vaccination records. And, but they sort of leave it up to more on the state level and your local government, and also your employer, who you work for, can decide to make these mandates for themselves. But higher up from the government level, and where, the people who are dispensing and giving the vaccines and sending the vaccines to us to get into arms, they are not mandating and requiring vaccination for people, but it's more sort of on a state or local government level, and a chat that you might hear from your employer as well, and they'll make that determination on their own as well. It's at their own employer's discretion. And then the other thing I hear is that, people will say, I'm going to test positive for COVID after I get my COVID-19 vaccine. That is actually not true either. So talking about the vaccines, it is just the little messenger thing that gets incorporated into, that's in the vaccine that tells your body to produce the spike protein. However, most of when we test for COVID, it's the kind of testing that we do for COVID doesn't exactly test for antibodies. And so it wouldn't make your test positive for COVID, nor will it give you COVID. There are no whole viral COVID pieces in the vaccine that could make you test positive for COVID or give you the COVID illness. And the next one is, people were saying, well, if I'm around someone who got their COVID shot, are they going to give me COVID? Are they going to expose me if they got their shot? So this is sort of the theory that after getting the COVID shot, that people are going to be shedding, do a little bit of viral shedding and being contagious to other people. This is actually not true. And so the idea that it does not give you COVID, then you won't be able to pass it on to other people just by getting the vaccine. However, if you have a significant exposure to COVID from someone out, that's been around you, you can get COVID and still pass COVID to other people, but it's not from the shot. And the other thing that's been out there and floating around is, I've already had COVID-19 and I got better and I've got some natural immunity to it, so I don't need to get the shot. That is actually, not, it is still recommended that you get the COVID vaccine, because the type of immunity, comparing natural immunity from having had COVID-19 to the type of immunity you get from the vaccine immunity is actually much stronger and more longer lasting than the immunity you might get from having had the virus. And so, and also with the variants out there, when you had COVID-19, you're only protected for that temporary, 2 to 3 month period after you had COVID, and protected from the COVID, the type of COVID that you got. Now with the variants that are all happening out there, the vaccine is going to protect you much better from those down the road. And then people, of course, are saying, once I'm vaccinated, I don't need to wear a mask anymore. That is not true. We all still need to continue wearing our masks. We need to still be careful and cautious, maintain our physical distancing rules, and just really follow up with all of that. Next slide. And so I've had a couple of people ask, what do I got my shot and I want my shot and I got it, and but the rest of my family doesn't want to, and how do I talk to my family to really convince them to that they should get their vaccines? And so people are sort of asking, how do I talk to other people? And so addressing this vaccine hesitancy out there with other people, just really making sure that you provide provide a listening ear mostly, and just really making sure that addressing things sort of in a supportive way, and just saying, I know there's a lot of uncertainty out there, but the disease is scary, and telling them your own personal sort of story. I got the shot, or I'm planning to get the shot. And, and I'm doing it for my family. My grandma lives with me, and I want to make sure I protect my grandma, and I don't want her to get it. And, it's a good idea that you get it too. Aren't you around your grandma too? I think it's a good idea. And so really having good discussions, in an emotionally supportive way is helpful, but also it's important to not dismiss the risks that worry us about it and that's floating around out there, but to acknowledge them. People react very strongly to any kind of new risk, all of these perceived risks from things that we all have no extensive long experience with, but we all have a lot of risks that we take in our daily lives. There's we have daily risks that we face every day. For example, we get into our car and we drive our car, or we ride our bikes and do activities that put us at risk for certain types of injuries. And knowing that the threat of COVID-19 is real and it's an increasing risk, and it's just it's sort of, we have to kind of put a lot of things in perspective and think about what would be most meaningful to us in terms of the type of risks we want to take. And so it's a good discussion to have with people in terms of some of the risks as well. And then really providing good information to people in terms of providing articles and reputable information, not sharing an article that came out in a gossip magazine or a gossip site, things like that, and really making sure that you're sharing information that comes from reputable sources, and just really help to combat some of the misinformation that's out there about vaccines and their safety and efficacy, and really partnering with other people. If you work in a place that that works with a lot of Native people, for example, sort of working with Native communities and acknowledging that, these problems are out there, and not acknowledging a lot of the risks and some of the background history and hesitancy that we have as a people, and just really creating longstanding relationships with community partners that a lot of communities come to and trust, and really making sure that everyone's on the same page. And I think most importantly, it's to really share your own personal experience with other people. You just can't tell people you got to get the shot. Go get it. And it doesn't really do very much to convince someone to go get their shot just because you told them to. But really showing that you're willing to do it openly, is even more powerful, and sharing that experience with other people, and your own personal motivations for wanting to get the vaccine is a bit more important, and means more to people when they listen to what you've how you've sort of thought it out in your mind. And just really tapping into people's desire to protect other people is really key as well. As Native people, we all come from extensive families and, large families. We care a lot about our family in terms of, who we live with. We all are very close-knit, tight families. And so when we talk about our pre-existing motivations to protect our family and our friends, and framing our discussions in that sort of framework about protecting not just yourself, but also the people you live with, the people you care about. And that can really sort of resonate more with people. But it's important to also not criticize the judgment of other people, not really talk people down, and do not use any scare tactics. I know there have been a lot of, ads and things that have been out there, and people have said, well, get vaccinated or you're going to die from COVID, and this is just not the approach to take. And it really, really takes some patience and good, quality time and understanding and discussions to really talk it out with people. Next slide. And so if you yourself are wondering, how, and sort of unsure about getting the shot still, just really think about your own unique situation. You hear a lot of buzz out there. There are a lot of ads out there. They may not necessarily apply to you. And you see ads out there and you think, well, that doesn't really sound like me, or it doesn't really hit you on a personal level. But just take some time to think about where you live. What do the cases look like in your community, in your household? Who do you live with? Does grandma live with you? Does, what conditions do they have, and the people that you're around, and where you work, and some of the risks that lie there as well. And then just really spending some time, and then put some time into talking to someone who can clarify and answer a lot of your questions. Talk out the things that you're concerned about, and just really clarify any of your misconceptions from reputable sources, being careful about where you get your information. And, and if you're religious, I've spoken to a lot of patients who have said, I've prayed about it. I still don't have an answer yet. I'm talking to my family about it, and I think I'm getting there, and I'll probably make an appointment soon, but I'm just really trying to get to a point where I'm fully comfortable with it. So those are very important things to do for yourself. Thank you. That's all I have for my first portion.
Thank you, Dr. Calderon. We will go ahead and just move on to Dr. Warren's presentation. And thank you everyone for submitting your questions. We will be getting to them at the end. We'll go ahead and move it over to Dr. Warren now.
Okay, sounds very good. And I really appreciate the information from Dr. Calderon. That was really great information and a very good overview of some of the key issues to consider. So I'll talk a little bit about public health perspectives, specifically strategies and considerations in working with tribal communities from a public health perspective. And from my own training, I am a physician, so I'm a medical doctor, but also have a master of public health, and I direct programs that are focused on medical training as well as public health training. But really what we need to keep in mind is that the public health approach is designed to prevent disease, and in medicine, we treat disease. So as we know, COVID-19, of course, there's a lot of things we can do to prevent the transmission of the virus, but also we have to be able to treat the disease once it is here. So we know that we have some significant challenges on both preventing and treating COVID-19 in our tribal communities. So I also like to point out that the whole idea of public health really is consistent with traditional medicine and traditional approaches to wellness. And in this region, there is a story of three sisters walking along a river. And as they're walking along the river, they notice babies and young children in the water struggling to stay afloat. So the first sister declares that this is an emergency, it's a crisis. We need to get the babies out of the water right now. And the second sister thinks about that and says, no, we need to teach them how to swim so they can survive while they are in the water. And the third sister keeps walking upstream, and the other two get angry with her and say, where are you going? Why aren't you helping us? And she replies, I'm going to find out who's putting these babies in the water, and I'm going to stop them. And that literally is public health. That's working further upstream, trying to prevent the problems before they become a crisis. And as we know, in Indian country, we have all kinds of preventable issues that have become health crises. And we have to have a much more strong investment in public health, health promotion, and disease prevention. And I think COVID-19 has shined a very bright light on the need for focusing on prevention and public health. When we think about the benefits of public health, this chart shows life expectancy in the United States. I know it's a little bit of a busy slide, but essentially in 1900, the life expectancy was about 45 years. So just 120 years ago, life expectancy was under 50. And then we fast forward to the year 2000, and it goes up to about 75 years. So that really is remarkable to have an increase in life expectancy of 30 years in the 20th century. And it's estimated that 25 of those 30 years of increased life expectancy are due to public health interventions, not medical interventions. So we have to recognize that public health as a discipline has had a huge impact on life expectancy. So life expectancy in the United States peaked in 2014 at about 78.9 years. Unfortunately, since that time, it's been coming down. So we're starting to see decrease in life expectancy. We've seen periods of time where that's happened in the past in terms of the 1918 flu pandemic, in which the life expectancy was significantly shortened. But we're starting to see this trend. And starting in 2015, we started to see the number go down, and it might be due to several things, including opioid epidemic, as well as higher rates of suicide, less focus on healthy nutrition. And we started to see this trend. And unfortunately, COVID-19 has further worsened life expectancy in the United States. So we need a strong public health approach. When we think about the top 10 achievements in public health in the 20th century, look at number one, it's vaccination. And vaccination has had a huge impact in terms of eradicating diseases like smallpox, but also improving the rates of things like measles, mumps, rubella, polio, Haemophilus influenza, and a whole multitude of other diseases that were at one point very common. So vaccination is a huge achievement. I think one of the outcomes of that is that the younger generations have never seen cases of polio. Younger generations have never seen epiglottitis from Haemophilus influenza. So it's kind of out of the collective memory how terrible these diseases are. And I think that's one of the reasons why we see vaccine hesitation among younger people, is that they don't have a history of understanding how bad these diseases are. So when I'm talking to community members, one of the important things is just to make sure we understand the terminology. So what is a pandemic compared to other types of descriptions? So a disease outbreak is when there's a higher than expected level of a disease. So you could have, for example, a salmonella outbreak, and you could trace it maybe to food safety issues and poisoned food, essentially. Or you can have an outbreak of COVID-19 in a nursing home. So it's when you see a higher than expected number of cases in a specific population or group. Endemic is when there is a disease that is very prevalent in a particular population. So for example, malaria is endemic to some parts of the world. And epidemic is when we see higher levels of a disease in an entire population. So sometimes we talk about the opioid epidemic in the United States, or the diabetes epidemic among American Indians as an example. And COVID-19 started as an epidemic in China, and then it spread across the world. So a pandemic is basically an epidemic with a passport. So we're in the middle of a pandemic related to COVID-19. In terms of how it affects us, I won't go into great detail. I think Dr. Calderon summarized the information really well, but we are disproportionately affected by COVID-19. We've known this for the past year or so. The CDC came out with a morbidity and mortality weekly report last August, describing that we are 3.5 times more likely to have the incidence of COVID-19. And unfortunately, we don't have adequate public health infrastructure or medical care to meet the needs of our people. And also wanted to highlight what Dr. Calderon also mentioned is that one of the pieces of good news is that for people who are fully vaccinated, American Indians and Alaska Natives have the highest rate of full vaccination. And I've talked to a lot of my family members, and I come from a family with a lot of traditional healers and medicine men. And in talking to them, they say that the older generation is familiar with vaccines. So they saw the direct benefit, for example, in the 1970s of worldwide smallpox vaccinations. And for those of us of a certain age, we had the little scar on our shoulder from the smallpox vaccination. We saw the benefit. So it's just anecdotal data at this point, but we do see differences in age groups. That the older populations seem to be much more willing to get vaccinated, and we're seeing more hesitancy among younger populations. So how do we address that? And I think it's important to also acknowledge that pandemics have been a part of Indian health history for many, many centuries. Even here in North Dakota, there was a smallpox epidemic in the 1830s that really decimated many of the tribes in this region. At that time, what is known as the Mandan, Hidatsa, and Arikara nations, they were so severely devastated that only about 130 people out of over 10,000 survived the smallpox outbreak that had occurred in North Dakota. So as a result, there were so few people left, they were brought together, even though there are 3 separate tribes, 3 separate languages, 3 separate cultures. They're now known as the 3 affiliated tribes, Mandan, Hidatsa, and Arikara Nation, largely because of a pandemic related to smallpox. So this is a part of our history. And even in truth, the origins of the Indian Health Service were designed to keep communicable diseases within the American Indian population and try to not have it spread to the non-Indian populations. So when we think about the history of the United States, colonization has had huge impact. And even in the Northeast, smallpox in some cases was used as a biological weapon and wiped out some of the tribes in the Northeast. So we've been dealing with this issue related to pandemics and loss for centuries. This is not new to us. And I think that's one of the reasons why, particularly among elder populations, we're seeing better rates of vaccination than among younger people. And it's because of those epidemics and pandemics and other issues that had occurred why we have the particular pattern of population we have now, where most of our people live in the western half of the United States because colonization started in the East. So here in the Great Plains where I work, we do see high rates of disease. We are seeing improving rates of vaccination, but unfortunately, disparity in terms of mortality rate. So I like this slide a lot, and I use this in many of my presentations, and I'm sure many of you have seen this or similar diagrams. And this is showing the difference between equality and equity. And in equality, we can kind of think of that as a one-size-fits-all approach. And on the left here, you can see the box that each person is standing on can be considered maybe a package of services, like health services, or maybe an educational curriculum, or perhaps a public health agency. So in the one-size-fits-all approach, we can see that the guy on the left did not need those services. It's serving the one in the middle pretty well. The guy on the right is still underserved. So we can't just look at things in terms of the package of services. We need to look at outcomes. And in equity, we're trying to look at equitable outcomes, not just the process in terms of services that are provided or curriculum that's provided. And we recognize that some individuals and some populations need unique interventions, and we can't just take the one-size-fits-all approach. That's been one of our challenges in public health, is the whole idea of evidence-based practices. That's kind of a one-size-fits-all approach to public health, because when we say evidence-based practices, my question is always, whose evidence is it? If a program works effectively in Boston or Atlanta, that doesn't mean it's going to work effectively in Pine Ridge or in Navajo, for that matter. So we have to be smarter about this and recognize that our approaches to populations need to reflect the needs of those populations. And I think that's been one of our challenges in the COVID response, is trying to understand how can we best engage younger populations and tribal communities. So I've been showing that slide for years, and a couple of years ago, someone sent me this picture, which I think is just brilliant. And the question is, do we just need to focus on a package of services to overcome the barrier, or do we need to get rid of the barrier? And one of our challenges in Indian health is that we do not have the infrastructure needed to adequately address the health challenges that we're facing, including from COVID. So on this slide on the left, that's a graphic right from the Indian Health Service website, and it describes the legal basis for federal services to American Indians and Alaska Natives. And one of the primary reasons we have a legal right to health services is our treaties. So we have hundreds of treaties that were signed between tribal nations and the federal government. So from a policy perspective, a treaty is the highest order of law in the land. There's actually a treaty clause in the US Constitution. And on the right, this is one example of a treaty. This is the Potawatomi Nation Treaty in 1846. And I know it's in fine print at the bottom, but basically it states that the Indians will give assurance of fidelity and friendship to the government and people of the United States, and the United States will give at the same time promise of all proper care and protection. Promise of all proper care and protection. And in truth, historically, we have not received all proper care and protection, have we? Even when we look at COVID-19 and public health infrastructure, I look at this as the US government being in breach of contract. You know, they are not living up to the treaty responsibilities to ensure that we have all proper care and protection. And this is common language in many of our treaties, but unfortunately, IHS has been terribly underfunded. And I'm sure many of you have seen this slide or similar one showing the funding disparity for Indian Health Service. So from my perspective, this is a systemic barrier. That is the wall standing in front of us, where we have other populations in the United States with significantly more resources to address health needs than we have in the Indian Health Service. Now, we have seen some significant improvements here in recent years, and I think certainly with the COVID response and targeted resources to address this, I think we're going to close that gap. But it's an ongoing problem that's decades old, and it led to a lack of public health infrastructure. So when we think about public health infrastructure, you can see on this particular diagram, the base of that pyramid is workforce capacity, information and data systems, and organizational and systems capacity. So I look at the workforce really as the muscular system, the information and data systems is the nervous system, the organizational systems is basically the skeletal system. You know, that's basically people, computer systems, and buildings and other types of infrastructure. So we don't have that basic infrastructure to the same degree that other populations have. So when we think about those capabilities that really are dependent on basic infrastructure, things like surveillance of disease outbreaks, epidemic investigation, and laboratory practice is limited in many tribal populations because of a lack of infrastructure. So our public health response to something like the COVID-19 pandemic has been hampered by decades-long underfunding of the Indian Health Service. We have to just be honest about that. The federal government has had a direct hand in limiting our ability to respond to this pandemic to the degree that we need to prevent those disparities in hospitalizations and death that were described by Dr. Calderon. So if we think about the impact of COVID-19, obviously we need public health infrastructure to respond well. We're at a disadvantage. That's a systemic barrier for many tribal nations. It's just the lack of adequate public health infrastructure. And then when we look at the response, you may have heard of the 3 T's that are described in terms of the response. It's testing, contact tracing, and treatment. And we've gotten better at this, but when we started dealing with the pandemic, it was very clear that we had inadequate testing in many of our communities. We did not have the workforce that was well-trained to do adequate contact tracing. And then certainly treatment. Most of our reservations don't have hospitals. The ones that do typically don't have intensive care units or respirators, those types of things that are needed. So our infrastructure on the medical side and the public health side has led to worse outcomes. And we just have to be cognizant of the fact that that's a policy-based issue in terms of underfunding of the IHS, and that is 100% the fault of Congress. They have been underfunding IHS for decades, and our ability to respond to the pandemic was hampered as a result. So in addition to those 3 T's, I would say the 4th T is trust. And again, Dr. Calderon had mentioned that in her discussion as well, that we need to have trusted agencies and trusted entities when we have a public health response. And I think some of the politically motivated things that are being said about public health systems, or even Dr. Fauci, is having a negative impact on trust. And if we don't have trust within the communities, we're going to see less vaccination. If we see less vaccination, we will never get to herd immunity, which means the disease will smolder and we'll continue to see new variants, and it will be an ongoing problem in perpetuity unless we can adequately vaccinate. And then of course, another big challenge, we know we have a lot of comorbidities, higher rates of diabetes, higher rates of smoking here in the Northern Plains, higher rates of heart disease and lung disease. So we see much greater risk for hospitalization and much greater risk for death from COVID when we have those types of chronic diseases. So when we think about COVID-19 vaccination, again, trust is a big issue. And that's where I think, again, we can't take the one size fits all approach, that we have an evidence-based practice of public health communication that's been tested in Atlanta. Well, that doesn't matter to us in Indian country. We need our own messengers and trusted messengers that can actually deliver meaningful information and the health communication. So we have to have targeted ways to engage our communities, whether it's elders or younger populations, around the need to vaccinate. And that's where we need to be more creative, and we need to ensure that we have community directed and community specific responses, because the messenger really matters in Indian country. Who's delivering the message in many ways is even more important than the message, because whether or not someone's even listened to. And then I think Dr. Calderon went through some really good description of the myths around vaccines and how they work. And one of the areas that I think is very important to remember is that a vaccine does not prevent your exposure to COVID-19. It just prevents you from getting sick from it. So the vaccine works in your body to strengthen your immune system against the virus. But it doesn't mean that the virus goes away from the community. It just gives you the strength to fight it off. So I've seen here in North Dakota, they talked about there was a nursing home where everyone was vaccinated, but still 11 people tested positive. So therefore the vaccine doesn't work. Well, no, that's actually 100% not true. What it tells us is that the vaccine is working appropriately. So again, the vaccine doesn't prevent your exposure to the virus. What it does is it prevents you from getting sick and dying from it. So that's also why it's important to still wear masks, if we're around others who are not vaccinated, and that we don't have all the data to know for sure, but it is conceivable. You could be fully vaccinated, you could be exposed to the virus and then potentially pass it to someone else. So when we're wearing masks, we're also protecting others. So in terms of strategies, is this about just us as individuals, or are we looking at the communities? The whole idea of being communitarian and doing things that are good for the greater population, not just for ourselves, are vitally important. And in Lakota, we say mitakuye oyasi, which means we are all related, or we are all connected. And I wish that we had that approach more broadly in the United States. I wish that we genuinely cared about each other more than we do, because this sense of individualism, individual entitlement at the expense of communities is not good for public health. And we're seeing that play out in many populations here in the United States. So I think having our traditional approaches and culturally relevant messaging with local respected champions as the messengers needs to be done in our communities. And that's where we need to put our next wave of resources and efforts. All right, I'll go ahead and end it there and pause and see if we have any questions to address.
Thank you so much for your presentations. We will get into the questions, and of course, if anybody else has any other questions they want to submit in the Q&A box, please do so. The first one we will gear towards Dr. Calderon. Back when the FDA was testing the safety and efficacy of the COVID-19 or COVID vaccine, the Navajo Nation was selected or agreed to be tested on as a population. In my opinion, this was not the best strategy to to test how the larger United States population would react to the vaccine, because Native Americans may have genetic makeups vastly different than other races in the US. In your professional opinion, do you think the testing of safety and efficacy on the Navajo Nation was ethical?
Great question. You can look at this from various perspectives, and there are, the vaccine was tested in multiple different populations across the United States, and the Navajo Nation was selected as one of the sites to help in this process. And so when we think about treatments for things, and you could sort of look at it from the other perspective, that if we only had tested the vaccine in non-Native people and only, let's say, just Caucasian people, we wouldn't really know if there are any particular differences that would be notable for, or things to note for even Native people. And especially among a population like ours that was very hardly hit with COVID, it was very important at that time to get a bit more data from our own local resources as well. And so, when we test things and we sort of, test is sort of a not a really great word, but when we sort of roll out things like this, it's important to sort of get some data on what's really happening among the people that would benefit greatly from this. And so the data, I think, was really important to collect from our Native people as well, and and to really sort of use that and give us some strong support for the rates that turned out to be great for us in terms of protecting and preventing further spread. So we were just one of the sites, but it was definitely across the entire United States that the vaccine was tested. But I think ours was also instrumental for us as well.
Thank you for your answer. I'll read the next question. This one will be for Dr. Warne. There has been hesitancy by some spiritual religious people in regard to the ingredients that they have heard in the development of the vaccine. So the examples given are like the snake lipids or fetal cells. What should we tell those individuals, or what would you tell those individuals?
Yeah, I think it would be first, let's make sure that the information is accurate in terms of the components of the vaccine itself. That would be important to do. But also, each individual does have the right to make those decisions. But I think that what we also have to recognize is that really what's happening is it's a powerful medicine to make our body stronger to fight COVID-19. So if there is a religious or spiritual basis for not taking the vaccine, we have to be respectful of all perspectives. But let's make sure it's based on accurate information. I think one of the challenges that we face is a lot of misinformation that people are making their decisions on. And in truth, what we really need to focus on is that it will strengthen us and give us a better ability to fight off COVID-19. So and just make sure that the information they have is accurate. And if so, we need to be respectful, but let's also focus on the benefits of vaccination as much as we can.
Great. And I also see Dr. Calderon is answering some questions in the Q&A box as well. So thank you for that, Dr. Calderon. The next question is from Tyrell. I saw you were kind of typing in the answer to that question, Dr. Calderon, but it says, recently I read that the US is reaching a vaccination rate plateau, and this may prevent the US from successfully reaching herd immunity. Can you explain more on that?
Yeah, certainly this idea of herd immunity is very important, just to really sort of as an overall community, getting back to, some sort of normalcy of things, getting back to sort of routines and some of the things that we've been doing previously. And so this idea, I think in general, we sort of look at herd immunity, if we can sort of reach at least greater than 70% of the population that can get the vaccine, that's a pretty good percentage to aim for to sort of get this herd immunity. I believe in the United States, we're just barely over 50%. And so, and the rates are definitely slowing down in terms of who, the people that are out there that are still hesitant to get their vaccine. And so hence forums like this and other people that really need to spend a little bit more time talking to each other and trying to seriously consider, getting the vaccine and being able to get more people to sort of thinking about it a bit more and to consider their own personal lifestyles and what's going on in their lives and what they care about most to try to get back to doing again. And so there is definitely that concern, especially as, the variants are popping up and the variants from other countries are spreading, there's a bit more urgency and push to really make sure that we sort of get more people vaccinated to prevent the ongoing spread of that and sort of these more dangerous variants from popping up as well. So there is a lot of concern for that. And hopefully, with more education and the more we can sort of reach out to people that are still unsure and making sure we clear up misconceptions and put out good culturally relevant information to get it all out there and really talk to more people and make sure that we're all sort of making sure that all of our relatives are all protected.
This next one is from Cassandra. It's more of a statement, but Dr. Warne, I think it would be great if you could elaborate on this one. It just says, this is another post-traumatic experience that we're having, the COVID-19 pandemic. I think it means like it relates to Native populations.
Yeah, and I completely agree with that. And one of the big challenges that we see is social isolation when people are responding to a pandemic, whether it's quarantine or isolation. I wish we had never used the word social distancing. It should be physical distancing. 6 feet is a physical distance. That's not social. You know what I mean? If anything, we need social connectedness now more than ever. So I just wish we never had the term social distancing. So I think with more social isolation and even think about, kids who are not getting the typical socialization in preschool or elementary school, that is going to have a long-lasting impact for many populations, not just American Indian. But I do think that the higher rates of the disease and higher rates of mortality will be one more traumatic event that our people are going to have to deal with many years to come. We've lost a lot of elders, we've lost a lot of knowledge keepers, and we've just seen excess death in our populations. And again, because of the lack of infrastructure, if we have a patient who's exposed, how do you do appropriate quarantine when you have overcrowded housing and you have poverty? So just some of the simple public health responses we're not able to do as effectively because of a lack of infrastructure. And that will lead to ongoing unresolved trauma related to the pandemic. So I agree with that. And it's just going to continue to smolder if we don't get adequately vaccinated. So I agree with what Dr. Calderon had said in the previous question, is that we're not going to achieve herd immunity at this current path. And what that means is it's going to be a smoldering problem for decades to come. So we have to get better at vaccination rates.
Great, thanks. And we also had somebody post about the current CDC updates on mask requirements. So thank you for posting that for everyone. The next question is from Chloe, and we'll give this to Dr. Calderon. Is data showing if vaccinated individuals can give COVID to unvaccinated individuals?
Yeah, that's a pretty good question. As we're approaching, month number 6 of our vaccine rollout, and we're still collecting more and more data on all of these questions in terms of vaccination, sort of how it leads to, how much transmission sort of. How much it sort of dulls transmission and things like that. So right now the data is showing that those who are vaccinated are less likely to give COVID to other people or not. But of spreading COVID. If someone was one of the unlucky, 5 to 6%, if they got Pfizer, Moderna, that got COVID after vaccination, their symptoms are typically milder. Most of them, most of them are asymptomatic, and so they would be less likely to spread COVID to other people. So transmission from a vaccinated individual is less.
Thanks, Dr. Calderon. We also, when people registered, we also had some questions come in that people could submit at the time of registration. So I'm going to read one of those for you, Dr. Warne. The question is, what are successful community strategies to encourage tribal members to get vaccinated? And I think it could also go along with one of the questions in the chat about community health worker models. Could you just elaborate on that?
Yeah, what I've seen, at least in my own communities, and it's more anecdotal because we haven't necessarily done all the formal data collection related to that question, but what I have seen is the messenger really does matter. In my own family, one of my uncles is Rick Two Dogs, and he's a well-known medicine man at Pine Ridge. And he's been very vocal advocating for vaccination. And I know he's had an impact on increasing the vaccination rates in the local community. So again, we don't necessarily have the good scientific data to support that. It's more anecdotal, but I really believe that the local champions, the people who are most respected in a community, are the ones who are going to be the most effective messengers. And sometimes it's a physician, sometimes it's not. Sometimes it's an elected official, sometimes it's not. So each community is different. So those local respected leaders are the ones that really need to be our champions in delivering the message. Then in terms of community health worker models, I'm a strong believer in community health worker models for all kinds of conditions, whether it's prenatal care or addressing addiction or really even managing diabetes. We need more community health worker models, and that's consistent with a lot of our traditional approaches as well. But I just know that a strengthened community health worker or community health representative in the IHS, strengthening those programs would only be a benefit, even for the COVID-19 pandemic.
Great, thanks. And I feel like this one can kind of be geared toward Dr. Calderon. It can be frustrating that the IHS is chronically underfunded. What is being done to combat this?
Yeah, I think a lot of leaders in our communities are actively advocating for a lot of things in terms of, as this pandemic has really shown a lot of the inadequacies in all the things that we've experienced here on our Native communities in terms of the poor infrastructure and things like that, and things that we sort of looking back on that unfortunately it's become a bit more obvious during this pandemic of all the things that we wish would be better and could be better to improve the health of our people, and perhaps might have been helped us to be better prepared to face a pandemic like this and not have lost so many people. But there are a lot of leaders in our communities that are constantly advocating for, better policies and better funding. And so, it just sort of goes up all the way up the chain, and really putting ourselves out there to, we do need definitely more people on the ground to sort of share their experiences with people who make decisions for, funding and things like that. And so it's really important to sort of make those connections, and for people and leaders in communities to, to voice those concerns and really get all this information out there. People who sit in higher up seats don't really see directly, what we experience day to day and what our people experience day to day. So it's really important for this information to get out there and to really share with the people who make decisions about this stuff.
Thank you, Dr. Calderon. And next question is, again, this was submitted prior, Dr. Warne. what can we do to encourage our relatives, our community members to get on informationals like this or other webinars, to, like you guys are saying, you know, come to their decisions on their own? So how could we encourage others to attend these types of events?
Yeah, that's a very good question and a big challenge. And I can kind of just speak to my own experience. What I've seen is that it's hard to get a lot of participation in these types of events. People have all kinds of other priorities and considerations and challenges. So I think these are very important events to have. And what we really need to do also is be out in the communities. Of course, that's a big challenge during a pandemic, and community engagement. But what I've seen is that when we actually take the time and the effort and the resources to do very direct community engagement in the communities, that's much more effective and better received. But of course, that's a big challenge when we're in the middle of a pandemic, but also we just haven't had the resources to do that active community engagement in most of our communities. So encouraging people to attend it's an important thing to do, but recognizing that a lot of people have other challenges and barriers just to participating in these types of events. So what I would love to see is more effort actually delivering this type of messaging within the communities and meeting people where they are. But of course, that takes a lot of resources.
Thanks, Dr. Warne. The next question for Dr. Calderon: what would be the right answer for a patient that wants to know why they did not get COVID when their spouse was positive, both continued to reside in the same housing and rooming as well?
Yeah, it's interesting because there are a lot of cases where similar things happened in families where, especially multi-generation households, you know, there are a lot of people living in the same house, and, you know, someone tested positive and sort of the virus sort of spread through the entire household, but spared a few people, you know, despite the constant intermingling that happens in the house. And so we don't know for sure, you know, what the full what could have contributed to that in terms of, you know, a couple of people being spared from being infected. But, you know, there are multiple factors involved, you know, in terms of, you know, we talk about when we talk about people sort of protecting themselves and living in a household that has been affected by COVID, you know, to really make sure that, you know, the air spaces are, you know, the spaces throughout the house are well ventilated and things like that. So there's multiple factors that contribute to, you know, how a virus is going to spread through the home. You know, and a lot of people have sort of picked up huge, have jumped on cleaning routines that are quite religious in their routines of cleaning and things like that. And so, you know, there are multiple factors that contribute to vaccine, how the virus is spread through a household, and you know, whether that, and there are still some investigations as well to sort of maybe certain predisposing factors that might make someone more favorable to not get infected. There haven't been exact release of data on things that sort of make people sort of more favorable to not get the infection, but there are multiple possibilities for that. But I think it is fortunate that there are some people that have been spared in households where there was exposure to the entire house.
Thank you, Dr. Calderon. I think we have a final question. Dr. Warne, we have a request. If you could just take a second to talk about your program at UND. There's somebody that's asking about it. Your Indigenous Health program at University of North Dakota. And then this will be our final question. I also just want to remind everybody, we're going to be doing our exit poll, which has just launched now. So if you could just take a second to please answer that. And then we will be sending a follow-up email with everybody register with the email that you use to register, and sending out results. Thank you.
Yeah, very good.
All right, Dr. Warne, it's all yours.
Yeah, I appreciate the question. We do have some unique programming at UND. In addition to the Indians into Medicine or InMed program, That InMed's been around since 1973, so it's almost 50 years old. And very happy to announce that last Saturday, we graduated 9 more American Indian physicians out of UND. So through InMed, we're getting close to 260 American Indian physicians graduating out of that program. Some of our newer programs, we have a Master of Public Health that has an Indigenous Health specialization, in which we look at issues related to colonization and how that's had an impact on health. Also the unique aspects of American Indian health policy and unique considerations for implementing the 10 essential public health services in tribal populations. And then just this last year, we started the first ever PhD in Indigenous health, where we're combining things like research methods, quantitative and qualitative methods, but also Indigenous methods, public health program evaluation, but Indigenous evaluation frameworks, and really taking a deeper dive into principles of Indigenous health. So our goal is to have cohorts of well-trained, culturally relevant researchers. And the reason for this is in my own experience, I've seen very good researchers, very good academics who don't have any lived experience with American Indian people or other Indigenous populations. So quite often they don't even know the right question to ask. You know, I've seen a lot of wasted time and wasted resources, just not even asking the right questions because the research community or the academic sector just doesn't understand Indian country. So we're trying to do our part to try to fix that. So we have a MPH in Indigenous health and a PhD in Indigenous health. And they just finished their last week of the first year of this PhD program. And we have 19 students in the first cohort. So 17 of the 19 are Indigenous people. And we have 18 who will be starting the next cohort in August.
Thank you so much, Dr. Calderon and Dr. Warne. We did have one last final statement from Cassandra, just talking about her concern for funding for substance abuse and suicide prevention, as well as domestic violence prevention. Of course, following the pandemic, she feels that our Indigenous communities need this funding more than ever. Our people are in need as much as possible of mental health, behavioral health services. It becomes a traumatic experience for a government who will potentially deny us these services. So thank you so much, Cassandra, for adding that. We definitely feel that it is very important to have those services as well, especially after the pandemic and as we still continue to go through it as well. So thank you so much for your questions, and thank you to our guest speakers for today, Dr. Calderon and Dr. Warne. We appreciate you taking the time out of your day to have this presentation and to give us this much needed information.